Okay, let's unpack this. The core of medicine, really. The fundamental question that every patient brings into the exam room is pretty simple. What is wrong with me?
Right. It's the central question.
But Harrison's Principles of Internal Medicine, I mean, this is the book for the field, makes it abundantly clear that diagnosis is not some neat, tidy algorithm.
Not at all.
It's messy, it's imprecise, and it's just profoundly fraught with risk. The statistics are, frankly, humbling.
They're shocking.
Yeah, I mean, studies show that common treatable conditions are still misdiagnosed at rates that the text itself calls shockingly high. We're talking 20 to 50% in some cases.
And that's exactly the tension we have to grapple with. If we connect this to the bigger picture, Harrison's is saying this isn't just about one doctor making a mistake. It's not just a failure of individual cognition.
It's a system failure.
It's a system failure. We're dealing with inherent uncertainty. You know, patients don't read the textbook. They come in with these vague, overlapping symptoms. So the vocabulary we have to use in practice, it has to include things like preliminary diagnosis or working diagnosis or even deferred diagnosis. Demanding a single definitive answer right away is, well, it's often impossible.
So you have this high-stakes balancing act. We know the process is ambiguous, but at the same time, we have this ethical, this professional mandate to manage that uncertainty without just becoming complacent.
Exactly.
And that is precisely where we are focusing our deep dive today. We're zeroing in on that critical section of Harrison's that's all about vigilance. It's about laying out the non-negotiable safety net.
Precisely. This part of the text pivots directly from acknowledging that ambiguity to then immediately establishing priorities.
Okay.
The text basically demands that clinicians build a kind of cognitive defense mechanism, a defense against conditions where any delay is either lethal or disabling. So our mission for you, the listener, is to really get a handle on these crucial concepts of don't miss diagnoses and red flags. These are the absolute threats that demand immediate recognition and action. It's a framework for safety that goes way beyond just ordering a few tests.
So let's get into that framework. This list of don't miss diagnoses, as you said, it's not random.
Not at all.
Yeah.
It's built on 3 very stringent high-risk criteria. These criteria are the stakes that decide whether a condition gets elevated to this critical status, demanding extreme vigilance from the very first moment.
So what are they? What makes a diagnosis truly non-negotiable in the eyes of Harrison's?
Okay, so first, we have conditions that are defined by rapid progression.
Meaning they get bad fast.
Very fast. These are illnesses that deteriorate quickly, relentlessly. A delay of just a few hours can be the difference between a reversible problem and permanent disability or even death.
And the classic example here is sepsis, right?
Sepsis is the canonical example, and it's stressed throughout all of modern internal medicine. We know for a fact that for every single hour you delay starting effective antibiotics and septic shock, the mortality risk just climbs and climbs.
So it's a time-sensitive emergency. You have to act before you even have all the answers, like the culture results.
You have to. And that really highlights the tension because the early symptoms of sepsis, fever, maybe some confusion or rapid heart rate, that can look a lot like a really bad case of the flu.
Time is life. Okay, so that's the first criterion. What's the second one?
The second is specific treatment dependency.
Okay, what does that mean exactly?
It means these are illnesses where the intervention you need is highly targeted, and you can't really start that therapy until the diagnosis is either confirmed or at least very strongly suspected.
So it's not just about managing symptoms. You need the right key for a very specific lock.
That's a perfect way to put it. A classic example is acute bacterial meningitis. You need specific, broad-spectrum antibiotics and often steroids, and you need them now.
Not tomorrow.
Right. If you wait, if you misdiagnose it as just a viral thing, the bacteria have time to cause irreversible brain damage or death.
So it's not just that it's urgent, but the urgency is tied to a unique intervention that completely changes the trajectory of the disease.
Exactly. And that brings us to the third criterion, which is broader than just the individual patient. It's about public health or contagion implications.
Things that affect the whole community.
Yes. These are diagnoses that affect society. They demand immediate reporting, isolation, contact tracing. Historically, this meant diseases like active tuberculosis,
Which requires a long, complex treatment and a lot of vigilance to stop it from spreading.
Correct. And as the text now reflects, this third category has been, well, it's been dramatically updated in the last few years.
I think I know where this is going.
Right. The inclusion of COVID-19 infection. It reflects this modern understanding that a critical diagnosis can be urgent, not just for the complications it causes in the patient like ARDS, acute respiratory distress syndrome, or blood clots.
But also for the immediate threat it poses to the community, to the whole healthcare system's ability to even function.
Exactly. So those three things together, rapid damage, a unique treatment, and societal risk. That's the cognitive filter for this don't miss list.
It's important to point out, as the text does, that clinicians are generally trained to spot the common emergencies. The textbook heart attack, the massive stroke.
Sure.
But this section really puts the emphasis on the less common ones, or maybe the atypical presentations of urgent problems.
Yes.
And that's where the real art of diagnostic vigilance comes in. That's what separates the expert from the novice.
That's absolutely right.
So to make this practical, let's actually dive into the list itself. We need to look at the specific diseases that meet those criteria. The text groups them by system infections, cardiac, metabolic, but maybe we can group them by the kind of diagnostic trap they represent.
I like that. Let's start with the infections that mask themselves as something routine, right, until it's far too late.
Let's begin with a spinal epidural abscess. The mechanism sounds straightforward, but the consequence is it's rapid and it's irreversible.
The mechanism is a race against time. You have an infection that forms this pocket of pus in the epidural space, right around the spinal cord.
Okay.
As that pocket of pus expands, it puts direct pressure on the cord. It causes something called myelopathy. And the consequences of a delayed diagnosis are they're devastating.
You mean paralysis?
Permanent loss of motor function, sensory function, bladder control, often, yes, irreversible paralysis. And the trap is that it often presents as just fever and back pain.
Which are maybe the two most common complaints in any hospital or clinic.
Exactly. So the vigilance comes from looking at the context. You have to actively ask, who is at risk?
So things like recent spinal surgery?
Recent spinal procedures, being immunocompromised like in diabetes, or, and this is a critical one, a history of intravenous drug use. If a patient has back pain that isn't getting better and they're in one of those high-risk groups, you have to order an immediate MRI, magnetic resonance imaging, to rule out this catastrophic compression.
Okay. Next on the list, necrotizing fasciitis. Literally flesh-eating bacteria.
Yeah, and the urgency here is tissue death that spreads exponentially. It's a rapidly advancing soft tissue infection where the bacteria release these powerful toxins that just destroy the fascia, the connective tissue around the muscles.
And the trap here is that the skin might look okay at first.
Exactly. Initially, the skin might just look a little swollen, a little tender. But the patient is reporting pain that is excruciatingly, completely disproportionate to what you're seeing.
That's the red flag.
That is a crucial red flag. If you miss that, if you treat it as simple cellulitis, the infection spreads under the skin, causing widespread tissue death, septic shock, and it demands emergent, often massive, surgical debridement.
So not just antibiotics. They have to physically cut out all the dead tissue.
They have to. It's the only way to stop it.
We also touched on meningitis earlier. That's the classic specific treatment dependency.
It is. The need for a rapid lumbar puncture to get cerebrospinal fluid and starting empiric broad-spectrum antibiotics, that's all paramount. You have to cover the likely pathogens before you even know what you're dealing with.
Because the difference between viral and bacterial meningitis is
life and death, potentially. Or life with severe brain damage. It all hangs on that immediate diagnostic action.
Okay, now let's look at two critical inflammatory conditions that cause their own unique, specific kind of harm. Guillain-Barré syndrome and temporal arteritis.
GBS, or Guillain-Barré, is a post-infectious autoimmune condition. It causes what we call an ascending paralysis. It often starts with just some mild tingling or weakness in the feet.
So why is it a don't miss?
Because that weakness can rapidly climb up the body, and if it reaches the respiratory muscles, it paralyzes them.
So the patient can't breathe.
Right. The patient might be reporting only minor symptoms, but could be just hours away from needing a ventilator to breathe for them. The vigilance here involves doing frequent bedside tests of lung function, specifically something called forced vital capacity.
And a drop in that number is the alarm bell.
That's the alarm bell. It means you need to intervene immediately with treatments like plasma exchange or intravenous immunoglobulin.
And then there's temporal arteritis, which is a favorite example in Harrison's for high-stakes, irreversible harm.
The harm is irreversible blindness. It's that simple. Temporal arteritis, also called giant cell arteritis, is a type of vasculitis, an inflammation of the blood vessels.
Okay.
It primarily affects the large vessels in the head and neck. If that inflammation hits the ophthalmic artery, it cuts off blood flow to the optic nerve,
Causing ocular ischemia.
and then sudden, usually permanent, vision loss. The diagnosis has to be suspected in any older patient with a new severe headache, maybe some jaw pain when they chew, or any acute vision changes.
And the rule here is absolute.
The rule is simple and absolute. If you suspect it, you start high-dose corticosteroids immediately, before you even get the biopsy to confirm it. Waiting for the diagnosis means risking permanent blindness.
Okay, that's a sobering look at the infections and inflammatory emergencies. Let's shift focus now to conditions where the internal plumbing, the vessels, the heart itself, fails catastrophically.
Right, leading to immediate shock or a critical lack of oxygen.
I think the king of misdiagnosis in this group has to be aortic dissection.
Mm-hmm.
People so often mistake the symptoms for a standard heart attack.
It's a classic, terrifying diagnostic trap. Yes, both involve severe chest pain, but an aortic dissection is a catastrophic tear in the inner lining of the aorta. Blood surges into the wall of the vessel itself.
And the pain is different.
Patients describe it as a sudden, severe tearing or ripping pain. And this is key. It often radiates immediately to the back, between the shoulder blades. Another key finding, often missed in the chaos of an emergency department, is a difference in blood pressure between the right and left arms. That signals a disruption in blood flow. And time is absolutely aorta.
Time is aorta.
If the dissection involves the proximal aorta, type A dissection mortality goes up by about 1 to 2% per hour. It's an immediate surgical emergency.
Just as deadly, but usually in the abdomen, is a leaking or ruptured abdominal aortic aneurysm, or AAA.
Yeah, if a dissection is a tear, a ruptured AAA is a balloon that has just popped. It typically presents with a triad of symptoms. Hypotension, low blood pressure abdominal or flank pain, and a pulsatile abdominal mass.
But you don't always see all three.
Often you only get 2 of the 3. The rupture causes rapid, massive internal bleeding into the retroperitoneal space. Recognizing it is key, especially in an elderly smoker with high blood pressure. Any delay in getting to surgery is often fatal from hemorrhagic shock.
Okay, let's talk about pericardial tamponade. This is a situation where the heart is literally being choked.
That's a great way to describe it. Tamponade happens when fluid, often it's blood after a trauma or inflammatory fluid, accumulates rapidly in the pericardium, which is the sac around the heart.
And that sac can't stretch quickly.
It can't, so the pressure builds up and it compresses the heart. This restricts the heart's ability to fill with blood during diastole, so cardiac output just plummets.
Leading to cardiogenic shock.
Exactly. Clinically, you're looking for the classic signs of Beck's triad: muffled heart sounds, jugular venous distension in the neck, and hypotension. An urgent drainage procedure called a pericardiocentesis is immediately life-saving.
Then we have the circulatory plug, a pulmonary embolism, or PE.
PE is very high on the mortality risk scale. It often comes from an unrecognized deep vein thrombosis, a DVT, in the leg.
A clot breaks off and travels to the lungs.
Right, and a massive PE, a big clot lodged in the pulmonary arteries, can instantly block blood flow from the right side of the heart to the lungs. This leads to acute right heart failure and cardiovascular collapse.
And the presentation can be tricky.
Highly variable. It can range from just some vague shortness of breath to sudden collapse and death. Using risk stratification scores, like the Wells score, is vital to decide if you need immediate anticoagulation or, for the really big clots, thrombolysis clot-busting medication.
What about the gut? You hear that acute mesenteric ischemia is one of the most painful things a person can experience.
It is the classic example of pain out of proportion to the physical exam. Mesenteric ischemia is a lack of blood flow to the intestines, usually from a clot blocking a major artery.
Okay.
The intestines are incredibly sensitive to a lack of oxygen, so it causes this excruciating, agonizing pain. Patients describe it as the worst abdominal pain of their life.
But when you examine them,
The physical exam is surprisingly benign. The abdomen is soft, it's not tender because the bowel isn't inflamed, it's dying.
and that discrepancy is the red flag.
It's a massive red flag. It demands an immediate CT angiogram and potential surgery to restore blood flow because a delayed diagnosis means irreversible bowel death, perforation, and shock.
Finally, in this group, we have 2 really severe localized bleeding emergencies: cerebellar hemorrhage and ectopic pregnancy.
Cerebellar hemorrhage is high stakes because of its location. The cerebellum is in a tight space at the back of the skull.
The posterior fossa.
Right. So even a small bleed there can swell quickly and compress the brainstem, which controls vital functions like breathing. It can also cause obstructive hydrocephalus. So even seemingly small symptoms, sudden dizziness, a bad headache, trouble walking demand urgent neurosurgical evaluation.
An ectopic pregnancy is the critical bleeding threat in women of childbearing age.
Correct. It is a critical don't miss because of the potential for massive, rapid internal hemorrhage. This is when a fertilized egg implants outside the uterus, usually in the fallopian tube.
And that tube can rupture.
And when it ruptures, it can mimic appendicitis or an ovarian cyst. Any fertile woman with abdominal pain or abnormal bleeding needs immediate testing quantitative HCG levels and an ultrasound. A rupture is an immediate threat to life requiring urgent surgery.
Okay, our third major category. This deals with systemic chaos. Internal chemical balance has gone haywire, or external toxins overwhelming the system.
Right, and we start with the classic metabolic crises. Diabetes ketoacidosis, or DKA, and hyperosmolar hyperglycemia.
Both of these involve just profound physiological derangement. The management is incredibly complex.
Absolutely. DKA, which you see more in type 1 diabetes, involves high blood sugar, severe dehydration, but also dangerous levels of ketones and a profound metabolic acidosis. The body is literally poisoning itself with acid.
And the other one.
Hyperosmolar hyperglycemia, more common in type 2, involves astronomically high glucose levels and severe dehydration, but without the acidosis. Both require meticulous, tightly controlled management.
Fluids, insulin, electrolytes.
Exactly. And continuous monitoring, especially of potassium. If you make a mistake, like giving insulin too fast, you can cause potassium levels to plummet, leading to fatal arrhythmias. Or you can precipitate cerebral edema.
Then you have the endocrine extremes, myxedema coma and thyroid storm.
These are the life-threatening poles of thyroid function. Myxedema coma is the extreme end of hypothyroidism. It leads to a life-threatening depression of mental status, hypothermia, and organ failure.
And treatment is very specific.
Very. It requires specific IV thyroid hormones and, interestingly, passive rewarming. Active rewarming can be dangerous. Thyroid storm is the exact opposite. A hypermetabolic crisis with high fever, severe tachycardia, GI upset, and delirium. Both require immediate, specific endocrine management that's totally different from routine outpatient thyroid care.
And another endocrine crisis that often presents very vaguely is Addison's disease, or acute adrenal insufficiency.
Yes, the diagnostic trap with Addison's is that the chronic form just presents as fatigue, maybe some weight loss.
It's very nonspecific.
Very. But Addison's is the failure of the adrenal glands to make enough cortisol. So when that patient encounters any acute stress, a stomach flu, a minor injury, they can't mount a stress response. They crash.
Into an adrenal crisis.
An adrenal crisis. They get profound hypotension, refractory shock, meaning their blood pressure won't respond to the usual fluids or pressors. The key is giving them high-dose glucocorticoids, steroids, immediately. If you miss this, the patient dies from circulatory collapse.
The text also flags B12 deficiency anemia. This one isn't an immediate killer, but it causes irreversible harm.
That's right. This is critical because of the neurological consequences. If you delay the diagnosis of B12 deficiency, the neurological symptoms, specifically something called subacute combined degeneration of the spinal cord, can become permanent.
Even if you eventually treat it.
Even after treatment starts, we're talking about debilitating sensory problems, loss of balance. It underscores that don't miss doesn't always mean immediate death. It can mean preventing profound, permanent disability.
Okay, shifting to environmental threats. The invisible killers, like carbon monoxide poisoning.
Right, or lead, or pesticide poisoning. These all require immediate recognition and specialized management. Carbon monoxide often presents subtly, like a headache or flu-like symptoms. You need a high index of suspicion based on the context, a faulty heater in the winter.
And the treatment isn't just supportive care.
No, it could require hyperbaric oxygen to prevent long-term neurological damage. For lead or pesticide poisoning, you need specific chelating agents or antidotes, and you need them right away. The environment is the vital clue.
And lastly, two rare but explosive crises. Malignant hyperthermia and tumor lysis syndrome.
Malignant hyperthermia is a pharmacogenetic crisis, usually triggered by specific anesthetic agents. It's a rapid, uncontrollable spike in body temperature, severe acidosis, and muscle rigidity. It's acutely life-threatening.
And it has a very specific antidote.
A life-saving antidote called dantrolene, which has to be immediately available in every operating room. And then tumor lysis syndrome is an acute complication, usually after chemotherapy for very aggressive cancers.
His cells are breaking down too fast.
Right. Rapid cell breakdown releases a massive amount of intracellular contents: potassium, phosphate, uric acid. This can cause fatal cardiac arrhythmias from the high potassium and acute kidney failure from the uric acid crystallizing. It requires urgent prophylactic management.
That deep dive into the list it's pretty sobering. It's clear that Harrison's is demanding that clinicians use this not just as a list to memorize, but as a proactive daily check against every single patient.
And that leads us perfectly into the next concept. Because that list is terrifying, but how do you apply that vigilance when 95% of patients with, say, a fever don't have one of these catastrophic conditions?
Right.
And that's where Harrison's gives us the cognitive triage tool, red flags or alarm symptoms.
So how does a red flag differ from a don't miss diagnosis?
A don't miss diagnosis is the condition itself, like a spinal epidural abscess. A red flag is the symptom or the clue that forces you to consider that diagnosis.
Okay.
The concept actually originated in clinical guidelines for evaluating low back pain.
Which is incredibly common.
Exactly. The vast majority is just benign muscle strain. The challenge is finding that 1 to 5% that's caused by something catastrophic, like a spinal tumor, a fracture, or an infection.
So the flags are designed to trigger an escalation in testing when a certain threshold is crossed.
Precisely. And the text details the classic back pain red flags. They're all proxies for some kind of high-risk pathology.
Such as?
Okay, so fever. That suggests an infection, like the epidural abscess we just talked about. Unexplained weight loss or a history of cancer. That suggests metastatic disease to the spine. Intravenous drug use is a major risk factor for spinal infections. And then, crucially, new neurologic signs or symptoms.
Like weakness or numbness.
Exactly. A progressive weakness, numbness in the saddle distribution, or new problems with bowel or bladder function. Those point to severe spinal cord or cauda equina compression.
So if a patient with back pain ticks even one of those boxes, your thinking has to shift immediately from muscle strain to I have to rule out something terrible.
You have to. And while this started with back pain, the text notes this systematic approach has spread to almost every common complaint: headache, red eye, chest pain. They're cognitive shortcuts for maintaining situational awareness.
But, and this seems really important, the text offers an evidence-based caveat about relying too heavily on these flags.
Yes, and this raises a really important question from the world of evidence-based medicine, or EBM. While red flags are incredibly useful for triage and for initial risk stratification, Harrison's is careful to caution that very few have been rigorously evaluated for their true diagnostic metrics.
You mean things like sensitivity and specificity?
Exactly. For example, some flags might be very sensitive, meaning they catch almost everyone with the disease, but they also flag a lot of healthy people, so you get lots of false positives. Others might be very specific, but easily missed. They are tools for structuring your thought process, not perfect diagnostic tests in themselves.
So you use them as a trigger for more investigation, not as the final answer.
That's the key.
Okay, so we've established this imperative. Don't miss the diagnosis. But that pressure, which is amplified by a fear of litigation, can lead to defensive medicine, just ordering tests just in case. Harrison's is very clear that this vigilance must be counterbalanced with prudence. That being a good diagnostician also means avoiding the harm caused by over-testing.
This is arguably one of the most important philosophical shifts in modern internal medicine. The text really emphasizes that being more conservative with testing isn't just about saving money. It is fundamentally about patient safety. It's about, first, do no harm.
Let's talk about the harms. What kind of harm does over-testing actually cause?
Well, the fear of missing the diagnosis is a powerful force. It's driven by our memory of the last bad case we saw, and it drives this practice of defensive medicine. Harrison's flags a few distinct types of harm that this causes. First, there's the direct harm from the procedures themselves. Unnecessary radiation from CT scans, the risk of bleeding or infection from a biopsy, the stress of the test itself. Then there's the financial and time toxicity, the cost, the missed work, the follow-up appointments.
And the anxiety.
The anxiety and the labeling. You tell a patient they need a test to rule out cancer, and even if it's negative, that anxiety can stick around.
But the most insidious harm you mentioned is the incidentaloma. I think we need to explain that in detail.
An incidentaloma, an incidental finding, is an unexpected abnormality you discover on imaging you ordered for a totally different reason.
For example,
You order a CT scan for suspected kidney stones, and you happen to find a tiny asymptomatic nodule on the lung, or a small non-functional mass on an adrenal gland.
something that probably would have never caused a problem.
Exactly. It would likely never have caused symptoms or shortened the patient's life, but once you find it, you're ethically bound to investigate it to make sure it's not an early cancer.
And that triggers the cascade.
It triggers an expensive, anxiety-ridden, and often risky cascade of follow-up tests, repeat imaging, monitoring, and maybe even an invasive biopsy, all just to confirm that the finding was benign all along. The text calls this harm delivered through an excessive search for certainty.
So the principle Harrison's advocates for is that a test must truly benefit the patient. The expected benefit has to outweigh the cumulative risks of that whole cascade.
Exactly. It forces the clinician to think not just, can I rule this in, but does finding this incidental thing actually provide a net benefit to the patient, or does it just introduce unnecessary risk and anxiety? It's a shift from a culture of maximal testing to a culture of judicious, thoughtful practice.
And while these core concepts, don't miss diagnoses, red flags are constant, the systems built around them must be evolving.
They are constantly being refined. A lot of this is driven by large-scale reports emphasizing that we have to improve diagnosis systematically, not just by telling individual doctors to be more careful.
How does that look in practice? You brought up sepsis recognition earlier.
Sepsis is the perfect example of institutionalizing a don't miss diagnosis. It's not enough for a doctor to just suspect sepsis anymore. The system has to force that suspicion into immediate action.
Through things like scoring systems.
Right, through formalized, rapid scoring systems like the quick sequential organ failure assessment or QSOFA. If a patient meets 2 of the 3 criteria-altered mental status, fast breathing, or low blood pressure, it acts as an immediate system trigger.
It sets off an alarm.
It forces the nurse, the resident, the electronic medical record to escalate care immediately, draw lactate, get blood cultures, start antibiotics and fluids within the first hour. It's a systemic effort to reduce that lethal diagnostic delay.
So the system acts as a mandatory safety net to override potential human error or delay.
Precisely. And another critical modern update is the emphasis on the context dependency of red flags.
Meaning a red flag isn't always a red flag.
Or rather, its significance changes with the patient. A minor symptom in a healthy young person might be safely dismissed. But that exact same symptom in an elderly patient or someone who's immunocompromised, that significantly heightens the risk.
Can you give a specific example?
Sure. Think about the failure to recognize atypical presentations. In a young person, sepsis usually presents with a high fever. In an elderly patient, sepsis might present with just mild confusion and a low body temperature. They might be febrile or even hypothermic because their immune response is blunted.
So the red flag looks completely different.
Completely different. Guidelines now stress that clinicians have to proactively adjust the sensitivity of their internal red flag system based on the patient's risk profile.
And finally, the rise of telemedicine. That has to be changing things when you can't do a full physical exam.
It's a major topic now. When the physical exam is incomplete, you can't palpate an abdomen or check reflexes. You have to compensate. You have to lean much more heavily on a really detailed, structured history, on risk stratification tools, and on carefully interpreted patient-reported symptoms.
So if I'm doing a telemedicine visit for back pain, I might not be able to physically check for saddle anesthesia, but I have to make absolutely sure I ask the specific questions about bladder and bowel function to compensate for that missing data.
Exactly. The system has to ensure safety is maintained even when the tools are limited. This requires embedding protocols for when a patient absolutely has to be transitioned from a remote visit to an in-person emergency evaluation.
Because failing to make that transition becomes the new critical diagnostic error.
It does. It all connects back to this idea of diagnosis as a system property. We have to engineer the environment to make it difficult to miss these things, even when humans are fallible.
So let's try to summarize this. We've covered a tremendous amount of ground, looking at how Harrison's manages this conflict between diagnostic uncertainty and the need for structured vigilance. We started by defining the 3 criteria that make something a don't miss diagnosis.
Right. And then we walked through those specific devastating conditions, from spinal epidural abscess to aortic dissection, and detailed why each one demands immediate action based on rapid progression, specific treatment, or public health risk.
We also detail the concept of red flags, highlighting their role as vital screening tools for common complaints, acting as triggers for escalation. And crucially, we balance that with the need for prudence,
Hmm.
discussing the harms of defensive medicine and the risk of that incidentalloma cascade.
The lesson is balance. The best diagnostician knows when to escalate, but also knows when to judiciously hold back to avoid causing harm.
So what's the practical daily takeaway from all this? The text concludes this section with 3 practical questions that every clinician should habitually ask about every single patient. It's a way to turn these concepts into a daily safety checklist.
These are the 3 essential questions, and they're designed to force a systematic approach and counteract our cognitive biases.
What's the first one?
Number 1, what else might this be? This forces you to consider the full differential diagnosis. It explicitly prevents you from falling into the trap of premature closure, of anchoring on the first likely explanation. If you think it's muscle strain, this question forces you to at least think about the spinal epidural abscess.
Okay, number 2.
Number 2, what doesn't fit? This is often called the most crucial question for interrupting diagnostic errors. It demands that you actively look for and interrogate any findings that conflict with your working diagnosis.
So you're looking for disconfirming evidence, not just confirming evidence.
Precisely. If you think it's simple gastritis, but the patient's heart rate is inexplicably high, well, that doesn't fit.
And the third question.
And number 3, what critical diagnoses are important not to miss? This injects that specific high-stakes consideration of the don't miss list right into your thought process. It forces you to systematically check the patient against that list of catastrophic, time-sensitive threats, no matter how mundane the presentation seems at first.
Those 3 questions, if you apply them every time, they move your thought process from passive confirmation to active, safety-focused inquiry.
It's the highest level of vigilance, applied every single day. And it encourages you to apply that same thinking to the system you work in, to ask if the culture and the technology are really supporting reliable diagnosis.
So the text really shows us that being a great diagnostician isn't just about knowing some rare disease. It's about having the organizational and cognitive tools, the don't miss list, the red flags, to prevent catastrophic harm from these urgent, time-sensitive conditions.
Exactly. Diagnostic excellence requires organized knowledge and systematic safety checks. The era of the lone, perfect diagnostician is giving way to the era of the reliable, safe diagnostic team, a team designed to catch inevitable human error.
And on that note, we'll leave you with a final, provocative thought, building on that idea of collaboration and follow-up. If the whole system is designed to catch the errors of a single clinician, what is the single most important diagnostic signal a patient can give you? The one signal that should override your initial hypothesis, even if all your tests came back negative.
The answer is implied right there in the text discussion of follow-up. It's the patient's failure to improve as expected. Or, even worse, the emergence of a new symptom that just doesn't align with the benign condition you thought they had. That sustained, unexpected deviation from the clinical course you anticipated, that is the ultimate red flag. It demands a complete diagnostic restart and a return to those 3 essential questions.
Thank you for joining us for this deep dive into how the masters of internal medicine structure their vigilance. We look forward to exploring the next section of your material soon.